So we're going to start our journey into therapeutic exercise. We've already covered the physiology somewhat of how muscles respond to exercise and how the cardiovascular system responds to exercise. And we're going to really focus on prescription. So I just need to do a tiny little bit of introduction with you from the perspective of how do we sort of define exercise as a modality that we're going to prescribe to our patients. So there's a couple of different, definitions that people use instead of the word, exercise. They may choose to use physical activity. So physical activity is, any sort of movement that's produced by contracting your skeletal muscle. And you should have an increase in your resting energy expenditure. Whereas exercise is physical activity that's planned and structured, and it's usually repetitive. Usually, exercise is what is relatable to physical fitness. However, when we look at different guidelines, and some of the certain patient populations that we work with, we do use the words physical activity because the word exercise is a little bit more daunting to some people. And we say, we just want our goal to be for you to engage in more physical activity. And those are the things that we, give recommendations to people in terms of park further away from the front of the store, take the stairs when you're at work, get up every 10 minutes, integrate more physical activity into your day. Whereas exercise, we might say something like, we want you to be, you know, walking at 5 miles per hour for 25 minutes continuously, 3 days a week, and incorporate some hills. That's sort of more of an exercise paradigm. But, we use both interchangeably depending on our patient population. So some of the things we're going to get into with this class are looking at how to, number one, make an effective exercise prescription, but number two, making it specific to our actual patient and what their needs are, because we are going to talk about normal and or typical, depending on what phrase you want to use. But when we're in the physical therapy realm, I would love for us to get reimbursed for wellness right now, but we don't, but that's coming. So we don't work with that many normal or typical people because we're working with patients. So we are going to be working with someone that has some sort of pathology of some kind. It could be that it's shoulder pain because of a rotator cuff irritation or tendinosis. It could be someone who is post myocardial infarction, right? So we run the gamut. So when we talk about fitness, we as physical therapists have to think of all of the different components that go into fitness. So first of all, we have to think about cardiovascular endurance. Does the cardiopulmonary system, cardiorespiratory system, right? Also circulatory system, is that all working effectively? Okay. So is our blood pressure at an adequate reading? What is our perfusion rate? How healthy is our heart, right? Can it maintain a pumping capacity to have someone exercise at a high level? All right, so all of those things we have to think about with cardiovascular endurance. The other thing we can think about with physical fitness is body composition. How much, fat mass versus fat-free mass do we have in the body? And fat-free mass can also be water, right? So a lot of people, if they undergo a fitness regime, they tend to lose some weight. That could be water weights, okay? Doesn't necessarily mean they're building muscle. So just, being sort of cognizant. Also, body composition, we can think of it on the opposite end of the spectrum when we think of people who are either older adults, or we can think of female athletic triad, which is now called nutritional deficit syndrome. These are people that have decreased bone density. So, right, that also goes into body composition. So we kind of have to think about all these things. What is their hydration level? What is our patient's bone density level? What is their muscle mass? What is their fat mass? So those are, the four components that typically go into body composition. Muscular strength. What is the force generating capacity of the skeletal muscle that they have? And then we'll have a lot to play around with that, in terms of what's the concentric capability of the muscle, what's the eccentric capability of the muscle, what's the asymmetric capability. Okay, so gross muscular strength, force production. Then we also have muscular endurance. So again, we're talking about muscle, but how many repetitions can this muscle endure, right? So you can have someone who may be able to lift a very heavy weight, but they can't lift a moderate weight multiple times, okay, because they're exercising that muscle to a capacity that it can't sustain, right? So it could be that the muscle is injured in some way. It could be that they don't have the correct metabolic drive to be able to sustain multiple contractions. They may not have the correct motor control to be able to sustain multiple contractions. So we do often separate out strength versus endurance. And then lastly, flexibility. So, flexibility can impact both muscular strength and muscular endurance if we don't have adequate range of motion available to us for a specific muscle, for example. So those are some different things that we work on. You can also look at skill uh, cutoff points or components and how they relate to physical fitness. So a lot of these I work on for things like return to sport, but also if you're working with, um, you know, a non-athlete, you need to be able to move towards function. So just because a person can have a certain force production with their quadricep muscle, that might not translate into them being able to walk across the street or being able to balance on one foot or navigating a curb. So yes, these words are commonly associated with athleticism, but they will also become very important when we're talking about just typical populations in regards to function. All right, so we have agility. Okay, so agility is the ability to change directions. It also incorporates balance. Um, it also incorporates things like being light on your feet. All right, so you can have many different components that sort of factor into agility. Coordination. So, is your patient able to, from the very basic level, like pass certain cerebellar tests that would indicate whether or not they are coordinated, but also things like, are they able to walk and carry on a conversation? Are they able to walk and dribble a basketball? Those types of things at the same time. Balance, very important. So you can think of this anywhere from if your patient is a gymnast and they need to be on a very narrow balance beam on one leg, all the way down to an older adult and being able to actually walk with a reciprocal nature, picking each one of their feet up off the ground because they will have to be balancing on one foot at some time. Power is going to be development of force over time. Okay, so someone can be strong, but they might not actually have power, right? So power indicates speed. So, we can have people that are able to lift a certain weight, but they do not have the ability to have this explosive nature. So we'll talk a little bit later about when you want to develop these certain skills in people, you have to work on them specifically. So you have to tax that system. So if I'm working just on someone for strength and I keep giving them heavy weights, if I never have them engage in plyometrics per se, or explosive or quick movements carrying that weight, they will not develop power. Just like if I never work on single leg stance, my patient could have the strongest quads or strongest hamstrings and strongest ankle dorsiflexors in the world, but their balance will not improve because I've never taxed that system. I've never had them actually work on balance exercises. Reaction time, that is almost neuromotor. So that is your ability to react. So a lot of cortical stimulation. You can work on it on the very basic level so that your muscles respond. But a lot of times you're picking up cues related, either to your vision or to other special senses that allow you to be able to anticipate a stimulus. For example, I was just talking with someone about how batters are able to hit a pitch that's traveling at 125 miles per hour. And they said, we don't even look at the ball at all. We're looking at cues from the actual pitcher. So we can tell, like, just by the way his arm moves, whether or not it's going to be a curveball or a fastball. So we anticipate the motion. And then lastly, just gross speed. So working more on activities that target like fast twitch fibers to be able to have you have movements that are quicker. One other thing that we will be talking about at length is how do we grade exercise? So how do we make it more intense or less intense depending on our patient population? So there's a couple of different ways that you can do that. And we'll be doing some testing in the laboratory setting in order to determine this. So one of the best ways, and it is the most scientifically accurate way, is to prescribe the intensity of exercise based on how much oxygen you consume during that exercise. So that's a direct relationship of how hard are you working, how much oxygen do you have to take in. So that's called your VO2 max. So VO2 max is very tricky to actually ascertain because you have to be working at your absolute maximal effort, meaning if someone's going to put you on a treadmill, you wouldn't reach your VO2 max until you essentially let go of the handles on the treadmill and let your feet go, and we're about to fly off the end. So most people, when they do this sorts of testing, they get to just before their VO2 max because they can't physically let themselves get to their maximum. But there is a lot of experimentation that allows us to extrapolate off of graphs. When you know someone's VO2 max, you know exactly how hard they're working. But that's not a very easy, cheap, accessible way to prescribe intensity of exercise, because that would mean you'd have to have someone with an oxygen tank either nearby or strapped to their back. You also have to only look at what their gas exchange is through their mouth. So you also wear nose clips. So it's quite tedious. So what we prefer to do is we have calculated VO2 max, and then we have also looked at a lot of data points that can associate VO2 max with heart rate. So we can say if someone's at 90% of their VO2 max, their heart rate should be at 80% of their heart rate max. So heart rate's a very easy, non-invasive thing to measure. So a lot of times we will take what the data tells us about VO2 max and then extrapolate it to be able to use other things that are easy to monitor. A couple of other things that can be used to do intensity. One is oxygen consumption reserve. So if you think about your VO2 max, and I said how hard it is to get to that, your VO2 reserve is like your submaximal effort. So there's also graphs that look at that. So get someone to exercise, continually make it harder, harder, harder. So you're looking at what their reserves are, and you can extrapolate to what their heart rate is, and then monitor that for exercise intensity. You can also look at what's called, we've talked about max heart rate. We can look at heart rate reserve. So we talked about in exercise in pathophys, your maximal heart rate is a good indicator. It's 220 minus age, but that doesn't consider sex. So there's a lot of variability inside of that. But on the flip side, it's a really easy equation to remember. Heart rate reserve takes into consideration your baseline fitness. So heart rate reserve takes your heart rate max, which is again based on age, minus what your resting heart rate is. So if you're very healthy, you have a lower resting heart rate because your heart doesn't have to work as hard to pump every minute. Okay, it's able to get out a lot of stroke volume. So you're still, the same cardiac output is coming out at rest, so then you can drop your heart rate because each individual contraction, your stroke volume's good. Okay, so your overall cardiac output stays the same. You're not exercising, you're at rest. So then it's like, I can drop my heart rate at rest. So someone with a low resting heart rate, therefore, is usually thought to be more healthy. So we would want to take that into consideration when we are figuring out their exercise intensity. So if you just did 220 minus age, everybody would have the same maximum heart rate. You would not know if somebody was healthy or not. But if you subtracted out what their resting heart rate was, that would give you an indicator their resting heart rate's really low. So that must mean I could take them up a little bit higher into that max heart rate stratification because they have a lot more play because their resting heart rate's so low. And the last way that we can look at intensity of either physical activity or exercise is by prescribing METs, which stands for metabolic equivalence. And I'll show you some graphs later that take different activities throughout the day, and scientists have, you know, sort of figured out a formula for how many metabolic equivalents something is. So they'll give you a range. So they'll say something like walking is 6 metabolic equivalents, whereas running is 14 metabolic equivalents. So you can prescribe exercise based on how much energy they will expend by doing a certain activity. I almost never use METs because it's hard for patients to understand. It's more of a sort of an academic exercise that we might use. So to go into METs a little bit more, if something is light physical activity, it's usually less than 3 METs. So that would be things like standing, to make dinner, some very slow walking. It wouldn't get you across the street in time for the walk sign. Moderate 3 to 6 METs, that's going to be more things like if you're really cleaning your house, like on your hands and knees, like scrubbing the floor, things like that, playing golf, playing ping pong. And then vigorous is greater than 6 METs. So that's walking faster than 4.5 miles per hour, jogging or hiking, shoveling snow or dirt, things like that, playing in a tennis match. Those are all considered, vigorous activities. Here's just a little graph of looking at the different metabolic equivalents. So you would know, right? Rope skipping. So jumping rope, that's a very vigorous activity. So that's a 12 MET activity, right? Whereas, it's significantly more than jogging. So if you're doing a 10-minute mile, that's, 6 miles per hour. Ballroom dancing, 5.5. So this just sort of gives you a graphical representation of how many metabolic equivalents you might expend with each individual activity. All right. So the one thing I want to get across with this class is we will talk about how physical activity is good for everyone. Okay. The only caveat to that is going to be people who have an absolute contraindication, right? And we'll talk about those in detail. Those are things like the person is actively having a heart attack. They're actively having a dissecting aneurysm. Like exercise is not indicated in those situations. The person has a pulmonary embolus. You're not going to exercise them. Just because a person has COPD doesn't mean you're not going to exercise them, but you're certainly not going to exercise them at the same level as you would someone who is running 4 times a week and is 18 years old. So there's gradients across the spectrum of what the exercise is that you are going to prescribe, and that's why you get paid the big bucks as the physical therapist, because you don't treat everybody the same. But so if your patient or client doesn't fit into one of those absolute contraindications, yes, you are going to exercise them. You are going to just modify it depending on their needs, okay, and level of pathology. So I show you this slide. This is from your ACSM textbook, where physical activity has such an impact on so many diseases that we deal with. And it's clear that it is an inverse relationship. So the more you exercise, the less disease you're going to be. So I have listed here all the different things that exercise has a positive impact on, cancers, diabetes, osteoporosis, hypertension, cardiovascular disease, depression, any sorts of anxiety. And then the figure that I have is looking at, is there evidence? Okay, so you can see, yes, there's evidence. The one I sort of want to draw your attention to is we have energy balance. So that's, weight loss, okay, or weight maintenance. Exercise, and we'll talk about obesity later, exercise is not the best strategy for that. Caloric restriction is, right? So I always give people the example. So a bag of potato chips is about 200 calories, a small bag, the snack packs that you get. You would have to run 6 miles per hour for 20 minutes to burn off that bag of chips, right? So to you, that might not sound like a lot, but think about the average population. Running, they would have to run. If they were going to walk, it would take them 40 minutes to burn off that 200 small bag calorie chips. So it's like, don't eat the chips. So people just physically don't have enough time in their day to exercise off the excess calories. There's a whole genre of literature talking about people who actually exercise a lot that don't lose any weight. And it's because they have this mentality of, I just exercised a ton, I should be able to eat more. And it's like they don't have a good understanding of how long it actually takes. You need to travel about a mile to burn 100 calories. So if you're running, You can do it a lot faster, but if you're walking, I mean, that could take 20 minutes. That's just 100 calories. That's an apple, right? So it gets really muddy with people thinking that exercise burns a ton of calories. So for weight maintenance, they don't know how much exercise it definitely helps, but it's not responsible. Like a lot of it is really caloric restriction. And then, in terms of cognition, they know that it helps for anxiety. It also helps for sleep. But in terms of, cognition, they think that activity helps. The issue that I've seen in the literature is that they believe it's vigorous activity. So they go on the side of caution in the ACSM book where they say there's insufficient data because they can't just say like taking a brisk walk is going to help you prevent Alzheimer's. They actually now are seeing that that's really vigorous activity helps prevent those sorts of diseases. But then it tells you the strength of the evidence. So these, are things that might range all the way from a Cochrane review. So that would be very, very strong evidence too. They might be more sort of like single subject design, case reports, or small amount of subjects in their study. But clear indicators, though, that physical activity and exercise help with many, many different health conditions. All right, so the last thing we're going to end on is what the recommendations are for healthy adults. So for those of you who either took exercise physiology before or have some sort of background or personal trainers or things like that and have based your principles on the ACSM, the entire textbook changed in February. So all of the recommendations are new. So it used to be you looked for risk factors and you categorized your patient based on different questions that you asked them or prior medical history, and you gave them a risk stratification, and then you put them in low, moderate, or high risk, and that dictated what you did for exercise. That is not even in the book anymore. So everything's completely changed. Likewise, their recommendations for exercise change. So you may have seen or been used to seeing, if you do moderate exercise, you should do 3 to 5 times a week, aim for 30 minutes each. They don't do that anymore either. So they're looking at total amounts of time. So for your cardiorespiratory system, for healthy adults, they recommend that you get 150 minutes per week. Okay? And they think the best way to get that is between 30 to 60 minutes per day. All right, so at the minimum, you want 150 minutes per week. If you are going to do vigorous exercise, you should go greater than 75 minutes a week. And they're saying the duration should be between 20 to 60 minutes per day. When they are talking about these exercises, they are talking about minimal skill type exercises. So the point is you want to do these multiple times a week, up to 5 times a week, maybe even every single day, because of the blood pressure lowering effects, the positive impacts on your heart, the positive impacts on your circulation. So if you are doing something that requires great skill, it's either quite difficult or it may leave you a little bit prone to injury, soreness, those types of things. So they're talking about like do exercises that don't require a lot of skill. Plus, it's good for everyone. So things like brisk walking, they want you to do that. So that doesn't require a lot of skill. So that means much of the population can engage in that type of exercise. And then, in terms of if you want to do a combination of moderate and vigorous, they're saying look at like the total dosage. So you'd aim for the 150 minutes per week. So there may be like you do moderate exercise 2 days a week, you do vigorous 1 day a week, you still want to get to 150 minutes. All right, other recommendations that they make, and again, these are for healthy adults, they recommend that you undergo resistance exercise. So they want you to do 2 to 3 days a week and 48 hours of rest in between exercising the same muscle group. So if you're doing, chest on a Monday, you want to wait until at least a Wednesday, because we talked about an exercise physiology portion of pathophys. For muscle to grow, it needs to actually incur damage, but then have a rest period. ACSM is also now recommending that you hit all major muscle groups. You want to hit multi-joint groups, so they don't want you doing like necessarily 7 different triceps exercises. They're going to say things to you like you should concentrate on push-ups and planks because it can work your core, it can work your glenohumeral joint, your elbow joint, wrist, okay, because that's all engaged. So you're getting a lot of bang for your buck. And they also want to encourage you to work your agonists and your antagonists. They recommend 2 to 4 sets. We will talk about this at length. 8 to 12 reps. This has to do with you will be about 70% of your 1 rep max. So people can do 2 to 4 sets and do 8 to 12 reps and not accomplish anything. But you should be very tired. This should be the total amount you are able to do. You should have exhausted the muscle after this. Okay. They're also encouraging 2 to 3 minute rest after each set. Again, bringing in that whole, like, you should be exercising to exhaustion. Excuse me. They encourage you to do full range of motion and implement both concentric and eccentric exercises to have completely well-rounded fitness. They also encourage you to do what are called neuromotor activities. These are especially important for the older adult, but they can definitely be beneficial in all populations, and those are exercises that are things like balance, agility, coordination, and gait. Gait was never ever mentioned by the ACSM before. This is the first year. So do these exercises 2 to 3 days a week for 20 to 30 minutes duration. So if you do, 20 minutes 3 days a week, that'll get you to greater than 60 minutes per week is the overall recommendation. And then flexibility and stretching. They want you to do this greater than 2 days a week. You should hit all musculotendinous groups, whichever ones are tight or are restraining you in some way. Ultimately, you want to hold greater than 60 seconds per joint. So there's a lot of literature that says 30 seconds is a great hold. But if it is painful and or you don't have a lot of range, you can do 10-second bouts. But then repeating it multiple times. So if you do 30 seconds twice, that could get you to your greater than 60 seconds per joint. And then doing a different variety of stretching techniques. So if just a straight stretch isn't working for you, try PNF. Okay, try contract relax first to enhance your flexibility. That's what that means by do different techniques. All right, so things that we're going to tackle in this class. What about patients? All right, so we have to think about, will the patient benefit from exercise training? And I can tell you the answer is yes, unless they have that contraindication. And then thinking of situations where it might not be a benefit. And we can think of things like that we tackled in patho. If you have a patient that has muscular dystrophy, is exercise a benefit? Yes. Is repetitive eccentric exercise a benefit to patients with muscular dystrophy? No, because it further damages their muscle. So it has to be the right type of exercises. Is the exercise safe? Okay, is your patient actually experiencing a stroke right in front of your eyes? Then no, you are not exercising them at that time point. All right. Or to think about, when is it safe? If a patient who has diabetes, perfectly appropriate to exercise, great intervention, but you don't exercise them when they already have hypoglycemia. Okay. Thinking about your current limitations, thinking also about what's optimal, right? That's your whole goal as a physical therapist, is what is the optimal treatment that I can employ at this time, right? And how can I do best by my patient? And then how much vigilance is appropriate or required? Can you use a PTA? Can you use a tech that you trained? Can you tell your patient to self-monitor at home? All right, these are all things that you need to consider and are part of your job. So more questions you should think about yourselves. Where will I start my patient? Right? I want to titrate. I want to have them be challenged, but I want them to do it again. So I don't want them to have an exercise routine that either hurts them too much or scares them too much, or it's just so difficult that they're super discouraged and they don't want to do it ever again. How am I going to measure their tolerance, right? When do I know if I'm going to be looking at shortness of breath versus heart rate versus rate of perceived exertion? Which one of those do I pay the most attention to? How am I going to detect an adverse event? How am I going to know if somebody's blood pressure is going through the roof? I better take their blood pressure, okay? How do I know their heart rate's too high? I better know their resting heart rate so I can measure, via intensity how high they're actually getting. Perhaps I should ask them their age. Perhaps I should ask them what medications they're on. All right. What are the signs that I'm going to be looking for, or the things the patient's going to be saying to me, or the qualities that the patient's going to be exhibiting in front of me? How do I know when to progress? How do I know when to scale back? Okay. And then how much do I do that? Right? Yeah, they're improving. I know I want to have them speed up, but how much do I have them speed up? I know my patient walked up one flight of stairs last week. When I see them in 2 days, do I put them 3 flights of stairs? You know, these are all judgment calls and things you're going to be dealing with on a daily basis. So that's what we're going to be accomplishing throughout these couple of weeks together. So I will see you on the next lecture.